So hello, good afternoon to everyone. My name is Javier Escanet, and I have the pleasure to be with Brida Hennessy as anchor, as a spokesperson in this session entitled Ultra-Low Contrast Techniques to Improve the Safety and Quality of PCI in Complex and High-Risk Patients. As you can see, we have with us a very nice group of colleagues, Dejan Milasinovic, Darius Dudek, Matthias Goldberg, and Nieves Gonzalo, who will be joining very soon. These are my conflicts of interest. Now, we are talking about ultra-low contrast PCI, but let me just make a brief reflection about the fact that the angiography was used for many years, but particularly the time that Andreas Glunzig developed it, to address all these different important questions that you have in coronary revascularization. I'm not going to go to the whole list. I'm just going to say that it's very interesting that still in many cath labs in the world, this is the same technique, the only technique that is being used for answering these questions, while in practice we have many other tools that can give not only an answer to that question like angiography, but giving a much better answer to these very important questions. Some of these tools have actually been developed to avoid performing contrast opacification, and I must, for example, refer to this dynamic coronary road mapping tool that is a tool that generates a dynamic mask of the coronary arteries based on a single contrast injection, and that, as you can see here from the results of the DCR for contrast trial presented last year at EuroPCR, contributes to spare the amount of injections that you need to perform, the amount of the contrast that you need to perform PCI. So the objectives of this session, as you can see here, are to understand how ultra-low contrast PCI contributes to improve safety and quality of revascularization of PCI procedures, particularly in complex and high-risk scenarios. We will try to share with you that this is something far more important than, or far more widely applicable than just in patients with chronic kidney disease. Also to learn specific ways of using intracoronary road mapping and physiology, as well as dedicated tools to perform PCI without contrast administration, and also to share the principles of PCI through recorded live cases to better understand how they work in practice. And with this, Brida, I think that we can invite the first speaker, the first colleague giving a lecture. Thank you.
Yes, so I think we have Dr. Dudek for the first one.
So Darius is going to guide us on why ultra-low contrast PCI is important as a sort of entry into this session. Thank you, Darius.
Thank you for the invitation for this interesting symposium, and I think on the technique which should be more and more commonly used in interventional cardiology. So first of all, we should know that the contrast is important, and we have the injury of kidney with the clear definition. We have usually the problems of our patient, and we should all the time look at GFR and try to use the same number of milliliters. If we have 14 GFR, we should use 14 milliliters, and this will be certainly safer for kidney and for patients. Does contrast volume matters? It means that yes, because from the old publication we know that the higher amount of contrast we have more frequently seen, we can see more frequently the contrast-induced nephropathy. Moreover, it is impacting the outcome of patients, especially the long term, that if you don't have the problem with contrast-induced nephropathy, you have the better outcome for your patients. Moreover, if we go for patients with CKD, a lot of physicians are afraid of doing intervention, but we know that revascularization is giving the better outcome than just pharmacotherapy. Sometimes we say the renalism, so it means that you have a lot of consultation between the cardiologist, internist, and nephrologist and GP to intervene or not for patients with CKD. And very often the only optimal medical therapy is recommended because many of physicians, they are afraid of the contrast and contrast-induced nephropathy or worsening of the renal kidney function. The same for acute myocardial infarction. We see that for patients with STEMI, primary PCI is less frequently used with CKD than patients without CKD. And moreover, the coronary revascularization is associated with lower mortality compared to medical therapy. So we should be more brave, but with the new and appropriate techniques. So that's why we introduced the concept over recent years of ultra-low contrast PCI, when we want to decrease the contrast amount, but also to improve the quality of revascularization, the completeness of revascularization, and to use the new techniques and technologies to make it happen. So that's why we are especially talking about the high-risk specific groups, like patients with renal dysfunction, but as well as patients with CTO or multivessel disease. Another clinical scenario which is challenging, like anemia, shock out of hospital cardiac arrest, very severe LV dysfunction, so heart failure, emergency PCI, and you don't know what is the GFR of your patient. Of course, frailty, we see more and more frail patients with aging. When we have the problem with the contrast allergy, hypothyroidism, coronary dissection, and once again CTO, nowadays even operators are able to do the retrograde approach without any contrast. In 2019, our group from Poland reported our approach step by step, and without any advanced technology, we're using just saline to introduce the guiding catheter into the ostium of left or right coronary artery, and when you see the changes, you are sure that you are coaxial inside and you don't need the contrast to be sure that you intubated your left or right coronary artery. Moreover, usually those procedures are staged, so diagnostic angio here on right coronary artery, and just with the two wires and just markering with those wires and the simple ultrasound probe, you can do stenting with very little amount of contrast, like 20 milliliters or even without any contrast. Only you can use for the documentation need. Also, you can use the very simple methods like metallic silhouette of the circumflex and marginal, and you can position your stent without advanced technology when you know the markering. Another example, putting the wire to small branch, which you don't intend to stent, but you know where to implant the stent and how to go with this procedure. Moreover, you can use other your devices like the distal part of the radiopack wire, 3 centimeters to measure the length. You can use ultrasound and the markers, which the clear distances on different wires. So really you should think twice if to inject contrast if really needed, or rather if not needed, to use the mapping, anatomic mapping with different devices. Nowadays, we have more technology, so not only technique is important. We have the cardiac CT, ultrasound, FFR, IFR, and DCR, so more advanced techniques used in interventional cardiology. So that's why we can use and we should use for the ultra-low contrast PCI the ultrasound and other imaging and functional and co-registration technique. And the best, of course, is to have the integrated lab when everything is on one screen, and you can use smoothly all those technology and in combination as the co-registration. So that's why in our newest manuscript, which is prepared for submission, we see that there are different steps of pre-procedural preparation, angiography settings, procedural safety, PCI planning and guidance, and assessment of the stenting, and with the focus on all detailed description how to avoid the contrast used. We should remember that we can impact the safety and quality. When we have on the regular PCI on the left, so usually we can do with the regular techniques and we should not add probably all those techniques. But if we go to all clinical scenarios which are more on right, including the CKD, we can have the impact of all those techniques and technology on safety and quality of our PCI, and we should remember every day on this. So that's why in this document, which is being prepared, we are also saying or more details how to be more coaxial, how to use the calcification markers, previous angiography or previous CTA, the saline injection, as I mentioned, even in some of experienced operators to use guide extension and to use catheters without side holes to avoid unneeded contrast use. Moreover, as I mentioned, technique is one, but technology is two. And we can use the functional coronary angiography. We can use the spot analysis with physiology or longitudinal vessel analysis for measuring our spots, and do virtual stenting to plan where we want to put the stent and not necessarily inject the contrast. As I mentioned, also the imaging is very important, especially with co-registration of angio and ultrasound, or in combination of physiology, ultrasound, and angio, if you have the advanced lab and you can do and you can afford. So finally, when really you need to inject contrast, we think that when you have the chest pain associated with ischemia, when you have the big ischemia changes, when you have the hemodynamic instability, new pericardial infusion in echo, and when you have the suboptimal physiology imaging result and you don't know the reason. So these are really 5 indications when you really need to inject the contrast. So in summary, I would say that CKD patients have the worst outcome, and many physicians are then afraid to do intervention, but we should do revascularization, but in appropriate way and using probably new techniques. However, out of the CDK patient, also we should use these techniques for more general use. We should use those techniques for contrast sparing and newest imaging technologies to perform ultra-low contrast PCI. It should be a bigger number of CAD labs, and I think that when you have the good lab with imaging, co-registration, and combination of physiology, you can do more, and you can improve the safety and quality of PCI, particularly in high-risk clinical scenario. So finally, I think that at this session and over recent years and near future, we are approaching the century of PCI with more medical technologies, lower contrast use, and radiation exposure. So it is a little different than Andreas Grinsing started almost 50 years ago. Thank you.
So we'd like to invite the audience. This is an audience participation. So if you have any questions, please don't be shy. Try to proceed or try to talk. Maybe Matthias, you'd like to kick us off with some questions?
So, Darius, in your mind, what is the biggest obstacle in terms of implementing ultra-low contrast PCI? Is it difficult to train an old or a new operator into performing ultra-low contrast PCI?
Yeah, so operators used to, they started with the contrast, so if they are not sure what's going on, they do the puff, and puff, and you should do more and more technology. So that I would say that if you are afraid of those techniques, you should start with regular PCI, and just to say every day that you can use the lower amount of contrast and train yourself. So after a few weeks, you will be much more experienced and reduction, because all those techniques can easily guide you and you don't need to puff again and again. So if you think to puff, so think also maybe I will see in physiology or imaging, and I don't need to do next puff.
Could you approach the microphone, please? Thank you.
Yes, thank you very much. I have a question. Would you more spare this technique for the elective PCI, or would you even be, let's say, brave to use this also in acute STEMI cases with CKD, maybe known CKD already?
Yeah, so I think that as for all intervention, better to start with elective cases to be well prepared and trained, but finally you can go for acute myocardial infarction. And as I mentioned, that many patients are not referred for interventional treatment due to CKD and acute MI, but if they know that your lab and you are experienced, so they will refer easily. So starting from elective, going to acute, then certainly it should be our focus.
I mean, as a matter of fact, you probably noticed that one of the potential indications is out-of-hospital cardiac arrest, where the patient comes with multiple, so to speak, damage or suffering in multiple organs, and it's certainly a situation where you know the toxicity of contrast is enhanced. So it will be a very typical situation where probably you would like to approach with just 2 injections, typically for the left coronary artery, epicranial, epicaudal. And from there, trying to understand, what is the situation, and perhaps proceed as much as you can without injection. In the right coronary artery, you can use 1 or 2 injections. But it's a good example that certainly these patients with an acute coronary syndrome are the ones that may be more prone to develop, actually, as you know, acute kidney injury, irrespective of previous renal function.
And moreover, with patients in acute MI, usually we don't know the GFR. So patients are coming and you don't know.
Can I have a question? And that is, how do you actually define ultra-low contrast PCI? I mean, we all sit here and speak about it. I see many smiling faces here. So how do you actually define it? I mean, is it as low as possible? Do you have thresholds? You've shown some of that on your slides.
Yes, so over last years we were saying about the zero contrast, about the low contrast, ultra low contrast, so it's confusing. So let's say the best rule is to give, as I said, the same amount of milliliters of contrast like GFR. This will be safe. Many people say that less than 20 is the definition. Zero contrast is still possible, so there are some cases when you use really zero milliliters of contrast. But in general, and the high-risk patients, of course, lower is better, and we say that low contrast PCI for many patients.
So it's more a mindset than a threshold, huh?
Absolutely, yes. I think there's a transformation of the angiography, PCI, which we did with, according to Andreas Grinzing, with contrast to new technologies which were not available at the time.
I mean, we always make the point, or I always make the point that I became an ultra-low contrast PCI operator, not because of kidney patients, but being a CTO operator. Because in every sessions about CTOs, you know that a liberal use of contrast puts you in a situation where you cannot complete a case, and you have to spare. So that's one of the reasons why whenever you are embarking into a very complex case, and that's the reason why this is a very important tool for cheap operators, you really have to refrain when you are before a very long and complex case in using contrast when it is not needed. So I will say that probably is like a LARA, as low as reasonable achievement in radiation. Same principle apply to contrast. Would you agree with that?
And moreover, we think also focus on the planning, that if you have previous angiogram, think that you have the mapping. If you have the CT, you should think that you have something before, and not all the time to repeat and repeat with paths.
So let's go to Dejan, who is going to make some reflections with the support also on some visuals.
Can we have the smart screen on to the technical team? Yeah.
Ready.
So, I mean, the question of the first presentation was why should we have this mindset of low contrast use? And of course, the kidney is the first association. And what I would like to make a further argument with this is that, more contrast doesn't necessarily give you more insight. Why is that? So if we analyze that there is a stent here, we look at it, and in my opinion, what you can definitely see on angio is whether there is a rupture. So yeah, that's an important information, of course. So checking whether there is a rupture, we do need angio for that. However, are we going to see on angio expansion, apposition, distortion? So when I say distortion, a recent intracoronary imaging guided trial in bifurcations showed that 20%, 18 actually, but close to 20%, have a distorted stent in the left main, which was seen on imaging, and of course you cannot see it on angio. So all of this you see with imaging. And you see here, of course, the rupture. So are you going to see more or less if you use less contrast? Actually, if you ask me, less is more. Less contrast is more insight. Because with intracoronary imaging, with this mindset that you do not need contrast, you actually gain more information. We are, of course, all trained. Me personally have been trained to use angio only. And as it was said, puff, puff, puff. Let's see it from this angle. Let's see it from that angle. Let's try to see it from here. And you're never sure. About expansion, you cannot be sure. About apposition, you cannot be sure. About distortion, which is, I think, a new big thing, at least when we approach bifurcations, you cannot be sure. So I think that, giving more contrast gives you actually less information. So less contrast is more information, I would say. I don't know if everybody would agree, but that's my tentative thinking about the topic.
I mean, it's a beautiful, beautiful way of putting it, and I fully agree. I think that the colleagues will agree. Would you like to make a comment? So less is more, a different way of looking to this important symptom.
I'm Dick Chris from the Philippines. I try to advocate the use of ultra-low contrast in my country, but I get a lot of reaction asking me, where did you get that figure of EGFR -1? Is there a trial that says EGFR -1 or EGFR +1 is all right? Is there data for that?
Would you like to answer that?
I think that, right, there are some controversies that just, the more contrast is not necessarily so bad. There are some opinions. Others say, as we know, that it could impact. But in general, when we look on, as Dejan presented, that you use the more technologies, we know that they are improving the PCI outcome. So if you use more ultrasound, more FFR, your PCI by itself is better. And at the same time, you can reduce the contrast. So I would say that not only contrast is the only focus.
I think you can, yeah, I agree completely. I changed the colors, so I think you can appreciate it better now, yeah.
Fantastic. So I think we probably could continue with a very important next lecture, which is giving us some clues on how to incorporate this in your practice. So Matthias is going to speak about how to incorporate ultra-low contrast skills to your PCI operator portfolio. Thank you, Matthias.
Thank you so much. It's great to be here. I think I'll try to dummy it down a little bit because it's actually not that hard. So we're going to do this a little bit case-based. Really, a step-by-step how to incorporate these skills into our PCI operator portfolio. And, if anything, if we can sort of think the credo for today, we should stop huffing and puffing, I guess. So here are my potential conflicts of interest. So this is a 60-year-old male. He presented at our hospital actually about a month ago. He has hypertension, he has polycystic kidney disease, and he's in CKD stage 5. And he was admitted with a non-STEMI, so troponin taken to the cath lab. So he's not that old, so obviously we should do an angio. Right coronary was good, and we did a couple of images with the guide in place, actually, so I didn't have to switch guides. And we found that it was one vessel disease, a tight mid-LAD lesion, some atherosclerotic disease beyond that. So it's not, it's not a super difficult case. If we would have additional disease, we could have done easily an IFR and FFR, and to make sure whether we needed to revascularize further or not. But since it was a one vessel disease, I decided to directly go ahead and plan this case. So one of my tool tips is really to plan your case before you start. I mean, I know we all want to jump at the gun and start doing PCI, but just have a plan in your mind of what you want to do. My plan in this case was wire the LAD and the diagonal branch, choose an appropriate pre-dilatation balloon for the case, do an IVUS, and then I had a preliminary stem plan, but it's obviously almost always modified based on the IVUS. So the other thing, which is also varies, is use reference images. When you've done an angiogram, you obviously have a few different projections. Most of them are often in one of the working views you want to use. This is oreocranial and LEO90. So we store these images on the screen, so we can look at them during the case. If possible, use two different views, and I'm going to show you why. So I wire the LAD using a standard wire. So is the wire in the LAD? Well, looking at the reference image, it looks like it probably is, but it's really difficult to tell unless we use another image as well. So in this projection, LEO90, we can see that it's in the LAD. In fact, there's no chance there's going to be anywhere else. And we haven't used any contrast. So instead of huffing and puffing and using lots of contrast to wire, we use zero contrast just because we have these previous images. We can also use side branches. Side branches are really important, either septals or diagonals, and such in the case of LAD. If we just put the wire in the side branch and leave it there, it creates additional landmarks for us when we perform PCI. We know where we're at in relation to the lesion. The other tooltip which you can use is you can use other anatomical landmarks on the angiogram. So if you look at the right-hand pictures, obviously you can put one wire in the septal branch and one in the diagonal branch, and you really cordon off the lesion. But you can also use other landmarks. So here's the shadow. and the shadow is pretty prevalent, it's at the height of the septal branch, it's really useful to know where your proximal landing zone is. The other thing is looking at the vessel angulations, vessel course. We know that the vessel goes downwards after the diagonal branch takeoff. So if we're using the same projections, we can actually use this to plan our stenting. These are really simple tool tips that we can integrate immediately without having any additional skill sets. And of course, we can use a coronary dynamic roadmap that was demonstrated before by Darius Dudek. We create essentially an overlay of the vessel into the live image, simplifying both vessel wiring and the stenting in ultra-low contrast PCI. So it's an additional tool that is really helpful for us to wire and not using any contrast at all. You just use the previous image. Well, using IVUS, of course, but not in the way you think. Well, the radiopaque markers on the IVUS, this is the eagle eye catheter, they do have a specified length. So we can use this measure stent length. So when we put the IVUS catheter down there, we can tell how far of a stent, far down the vessel we are and the length of the stent just by using this as a marker band. So more appropriately how we typically use IVUS in this case, we found out the distal landing zone was around 3 millimeters. The proximal landing zone was between 3.5 and 4 millimeters, depending on how you measure. And we found that it was a tight lesion, but it was not much calcification, so there's really no need for plaque modification therapy. We can just go ahead, pre-dilate, and then stent this thing. Another useful tip is using the SyncVision that we've been using ever since it was commercially available, and do an IVUS co-registration, which really simplifies the stent planning. And you can either use the previous image, or if you don't want to use any contrast at all, you can also use the wire for SyncVision vessel tracking, which makes it really easy to know where you're at and how to plan your stent, including stent length, actually. We didn't have to use physiology in this particular case, but if you have additional disease, the SyncVision physiology, the IFR pullback, really allows you to find the ischemic lesions and then plan your PCI accordingly, so you don't have to stent too much or too little. In other words, you will find the lesion that is causing the issue and how to stent it as well. And similar thing here, you can use contrast, but in case with a patient with severe CKD, you don't need to use any contrast at all. Just use the wire for vessel tracking, which is really easy as well. So let's continue with the case. Put in a stent 3.0 by 24 millimeters, proximal to mid LAD. I just looked at a healthy distal landing zone. Obviously, we don't need any contrast for this, right? No huffing and puffing. We use the anatomical landing zones. We use the side branch wire as well to know that we're in the right place. Obviously, we need to do proximal optimization therapy, so we're using a stent boost. Unfortunately, I didn't have that saved, but a really nice thing is to just use the wire in the side branch to know where you're at. And so we used the 3.75 NC balloon at high pressures, and we knew that we modified the carina accordingly as well. And then we just did the final IVUS, check the distal landing zone, which looks good, no dissection. And the proximal landing zone also looks good, no dissection, and we have a good stent expansion throughout as well. So the total contrast used for this patient was 26 milliliters. 20 of those was the angiogram before, and that's why I decided to not do an ad hoc PCI with 6 milliliters of contrast in total. And I had 2 dye shots. One that was a small puff immediately after I put the stent in to make sure I didn't have a rupture. And then I decided to do a 4 milliliter final shot, which perhaps I didn't have to do, but so 6 milliliters in total. So, if I may summarize this, it's really about planning your case, knowing which projection you work with and what kind of PCI strategy you want to use. Use the reference images. These are really easy tool tips that doesn't cost anything at all. Also identify the anatomical landmarks such as side branches, the vessel course, and you can use a wire to really find those anatomical landmarks. Obviously, imaging using IVUS is really important because it provides you with a safe way that is better than angio-based PCI. We know this regardless of CKD or not. And also, there are some really useful adjunctive technologies such as the SyncVision or dynamic roadmap that simplifies the strategy when you're during a PCI with the ultra-low contrast. There are some other things I haven't gone through yet today. So you can use diluted contrast, of course. Typically, you have to increase the frame rate a little bit to make sure you actually get a good opacification. So typically, for a case, I just use standard frame rate. But if I would use diluted contrast, I'd probably up the frame rate to 10 or 12 just to make sure. So there's a bit of a trade-off, but in this case, we don't want to use too much of contrast. So thank you.
I think, Matthias, you've shown us a beautiful case, particularly the type of case that maybe when you're starting with your ultra-low contrast program, the types of cases you should choose. So maybe just a question for perhaps Nieves. For these cases in your general practice, do you typically stage them or do you do them ad hoc, or what sort of approach do you take to them?
This, for example, this type of case, it was a non-STEMI and it's kind of a simple lesion, let's say. So I would do it on the same. I wouldn't stage it.
I think with maybe some of the more complex cases, sometimes you may have to stage them. But
no, but as you said, I think it's a very good example of how you can start with this type of cases and then build your experience. Because if you apply this very simple. Of course, technology is very important, but there are also some things that we all have in our cath labs are very simple, and you can apply and decrease the use of contrast in every single case. When you start doing these things, you realize how many contrast injections that are completely unnecessary are done in a normal case. So it's just a question, as you said before, of changing the mindset. And be conscious of, every time you inject, what is it for? It has to be for purpose, not just because you want to feel safe or you want to, without a real purpose.
So if I may, just one comment. I don't think lesion complexity is a big factor when it comes to using these skills. We don't have to use more contrast just because it's a more complex case. It takes longer time to do plaque modification, post-dilatation, etc. But it's not like we have to use contrast in that. The thing that decides contrast use is if you have to change guides, for instance, if you've got multiple lesions that you probably need a few dye shots to make sure you're in the right place. But a complex LED does not actually take more contrast than a simple one.
If you have any experience yourselves on ultra-low contrast PCI and you want to share, I see some operators in the room that actually are quite experienced. Please feel free to share your experiences as well. In the meantime, probably, Legend, perhaps you can help us or guide us through some of the learnings with the interactive screen.
Yeah, there was one. I think this was a nice case because it was a case of bifurcation PCI. And I think there was one moment, and that's performing POT, where I may argue that in some instances you would need a small puff of contrast. So I don't know how you see it, but when you're performing POT, you of course want to adapt the proximal vessel to the diameter which is larger. Now, using the boosted image, the enhanced cath lab image, helps you with the proximal edge very much. But if you want to be very precise at the ostium of the side branch, then it's a question. Of course, you can use the wire, but depending on the size of the side branch, it could be very large. So I think what comes in handy here is from the first presentation, you saw a diluted contrast. So how many of us actually routinely dilute the contrast? Routinely, no. Routinely, no. Yeah. But in the patients that you would have a kidney disease, you may dilute. So I think that even if you need a small injection, if you do it with a diluted contrast, you end up with a bifurcation case of 20 milliliters, 26 milliliters. So I think all of these small techniques help you in the end achieve the lower contrast volume. What I wanted to emphasize here is the following. So basically, you have a bifurcation PCI, and one of the first things when you approach a bifurcation is to be aware of the three diameters that you have. Diameter 1, proximal main vessel, 2, distal main vessel, and 3 is the side branch. So there is a difference in diameters, and when you try to size your stent based on angio, you're never going to be as accurate as when you size your stent here based on IOS. So that's the first reason why actually using a low contrast technique forces you to be actually more accurate. Second important thing is the landing zone. So basically, on angio, you can never be sure if you're here or here with a stent, for example, that you're not in a plaque. So behind your stent, of course, it's very important to know that the plaque burden is not, let's say, more than 50%. Can you know that based on imaging? Only angio? Not always. You don't really know how your landing zones are without intracoronary imaging. So once again, and I think this was a nice demonstration, having the ultra-low contrast mindset forces you to actually be more accurate with less contrast. So that was my takeaway. With this one discussion point, and that is the pot. I think performing proximal optimization technique, you need to have an instantaneous reaction. To have an instantaneous reaction, you have the knowledge from the IVUS co-registration, but you also need to be able to react instantaneously to the movement of the balloon. And I think for the proximal edge, stent boost, so enhancement is very good. But to be precise at the carina level, I would sometimes advocate a small injection of contrast. But of course, if it's a diluted one, you will end up with a smaller amount that you would expect at the beginning.
Fantastic, yeah. Very good comments, Dejan. So probably what we could do now is to see how all this is put together in practice, and for that, Dr. Nieves Gonzalo is going to share with us a recorded case in the cath lab where you can see how this is routinely performed in patients in whom ultra-low contrast PCI is deemed to be indicated or useful. So thank you, Nieves.
So thank you very much for the invitation to participate in this session. These are my disclosures. So the patient is a 72-year-old male that had a non-STEMI following a surgery for a colon cancer. And you can see it's a patient with a lot of comorbidities, including peripheral vascular disease and a previous stroke. He's also diabetic. He also has dysfunction, 45% ejection fraction, and inferior akinesia in the echo. Besides, he's a patient with anemia and renal dysfunction with a GFR of 40, creatinine around 1.6. So this is the angiogram that was performed after this episode of acute coronary syndrome. And you can appreciate already in these images that there is calcium, as expected in these patients with renal insufficiency. You can see tight proximal stenosis in the LAD, but also some degree of diffuse disease in the distal LAD. And you can also appreciate already collaterals to the right coronary artery. In the caudal views, you can see better how disease is the proximal circ, and I think you can also appreciate the presence of an occluded obtuse marginal. This is the right coronary artery that was occluded. And the patient was discussed in the heart team, and given all the comorbidities, the high risk for surgery, the oncologic status of the patient, it was decided that it was a patient to treat with PCI, LAD, and circ. And as you can imagine, it's exactly the type of patient that can benefit from the use of ultra-low contrast PCI. He has all the risk factors to develop acute kidney injury, including severe dysfunction, left ejection fraction dysfunction, plus anemia, plus already a previous episode of kidney injury. So this is the setup for the case, and the first thing we have done here is guiding cannulation, and then use the previous images, the previous angiogram, to wire the vessel. And this is something that really is quite good it's quite easy to do if you have the previous images. The next thing we wanted to do in this LAD was trying to understand whether treating only the proximal lesion was enough to achieve a good result. So for this purpose, we performed IFR co-registration. And in this case, you can see this co-registration can be done with a wire without using any contrast. You can see here that most of the pressure loss is located in the proximal lesion. You can also even estimate what is going to be the result that you can achieve if you treat this proximal lesion, which is, we thought, acceptable for this vessel. And then this is IVUS. And the purpose is, as always, trying to find good landing zones, distal and proximal, and understand how much calcium there was there, and if we needed to do any specific plaque preparation. You see, there was some calcium, especially in the proximal part, and the other significant finding was that really the vessel was diseased more than it looks in the angiography. In the proximal landing zone, we couldn't find a healthy spot, and we selected this area with less plaque burden as the proximal landing zone. So the next thing is now we need to prepare this plaque and we need to implant our stents. And as it was mentioned, we need landmarks for the delivery of the balloons and the stent. And in this case, we had two landmarks that we can use. We have, on one hand, the calcium. We have seen in the calcium where it is located. We have seen that there is no calcium, for example, in the proximal landing zone. And we also have a side branch, and we have put a wire there to help us. So this is the plaque preparation. In this case, it was done with a scoring balloon because we thought that the degree of calcium that the patient had could be treated only with balloon-derived technologies. And now we are implanting the stent. You can see we are positioning it, and we are just positioning it proximal to the calcium and distal to this side branch where we have the wire. So based on the IBUS that we have seen before. This is stent implantation, and then we perform a post-dilation with a forward balloon. You can see a little bit of waste on the part where there was where the tighter lesion was located, but that's why the reason why we wanted to check the result. And of course, we're going to check it now with IBUS.
So far, no contrast given to the patient.
No. So we saw the distal edge. So I think the sound is maybe a little bit low, but until this moment we have not given any contrast to the patient. And this is the IBUS pullback where you can see. Where we went with the 4.0, so you can see the stent here is larger and more adjusted to the vessel size. Let's see if we landed in the right area proximally. Yeah.
Looks so. Yeah, very nice. Yeah.
So we landed where we wanted, Lieutenant. We were quite happy with the proximal landing zone in this case, and also with the general aspect of the stem in terms of expansion. And this is the co-registration, and again, you can do now the co-registration using only the wire without any contrast. So you can measure the minimum stent area, assess whether there are areas of under expansion that needs to be corrected. And this is the assessment of the functional result using IFR. You see that we perform IFR pre, so we are checking now the result. That was similar to what we expected. In this case, we also used FFR that showed a normal FFR after the intervention. And here we're pulling back the wire, try to understand whether there are any focal changes or focal jumps inside the stent that needs to be corrected. We need to do some more post-dilation. And this is the first injection that we're going to do in the procedure. So you can see that we are filling the catheter. This is important also. And we are also acquiring at 30 images per second to improve the quality of the image, as Matthias was mentioning. So this is the first contrast injection of all the case. And the purpose of this injection basically is to understand if you have any perforation. And for example, in this case, it was also important to check the patency of this septal branch, very big septal branch that is providing collaterals to the occluded right coronary artery. So this was the end of the procedure for the LAD, one injection of diluted contrast, 3 cc's. After that, we moved to the circ, and again, the idea is the same. So we're gonna again wire this circ using the previous angiogram. We pre-dilated, in this case, the proximal part of the circ, and after that, we try to open the occlusion of the obtuse marginal using a double lumen microcatheter and a CTO wire. In this case, it was a Fielder XDA. You will see that after a few attempts, it was possible to cross this CTO in the obtuse marginal. You see the wire here crossing distally. And actually, at this point, we decided that it was a good moment to spare a little bit of contrast and make sure that the position of the wire was adequate. So you can see this is the second injection, again with contrast diluted. It was quite difficult to advance the devices towards this marginal, so we had to use guiding extension. And actually, we needed to trap and advance it using trapping because it was really difficult to advance any device into the marginal. But after that, it was possible to dilate this lesion in the marginal with a small balloon. This is again now a small injection to understand better the morphology of the marginal branch, because before it was really, really tight. And after that, of course, we followed the same strategy. So we assessed the vessel with IVUS to understand if there were any good landings. As expected, there was a lot of disease in the vessel. We had to land in an area with some degree of disease. Here we are using again the markers of the IVUS catheter to measure length. This is a very good trick that you can use. And now we are positioning the stents. And this is another trick, is using the radiopaque part of the wire, for example, when you have a bifurcation, to check again positioning of the stent. And this is the distal stent that we implanted, the 2.5 stent. We are pre-dilating a little bit more the proximal part with the balloon of the stent. Post-dilatation here with a non-compliant balloon. And after that, we're gonna implant the second stent. And here, for this, in this case, we are using, again, a side branch wire, in this case, in an intermediate branch. And we are using also a stent enhancement, which is extremely useful, of course, when you need to overlap stents. So you can see we are using also different views. So all these things that help you to position the stent without the need of using any contrast. So after the stent implantation, we post-dilated everything with a 3.5 non-compliant, the proximal part. And this is the IVUS after stent implantation. You can see the stent looks okay in the distal part. When we approach the proximal part, it looks like good. We could do some more post-dilation, especially when we approach the very proximal part that you will see here, where there is quite a lot of plaque part and the stent looks a bit undersized for this part of the vessel. So based on that, we post-dilated. This is a co-registration again of the IVUS, using, in this case, one diluted contrast injection. That was the last one of the procedure. So you can see this is the final result and the final injection. In total, 4 diluted contrast injection, 12 milliliters, and this is the final result in the circummarginal. So I think the message is basically showing you how a complex patient with multi-vessel disease, previous renal injury, decreased left ejection fraction is the type of patient that can really benefit from using less contrast. And it's an example of how these techniques were used and allowed treatment of 2 vessels, including a CTO, with a good procedural result, guided by imaging and physiology, and using a very low contrast volume. So thank you for your attention.
Yeah, it was a fantastic case, definitely a challenging case and a beautiful demonstration of how to incorporate all the techniques. Matthias, maybe you have some comments?
I think it was a beautiful case, but it also proves the point that sometimes you actually do have to use contrast. I mean, we're not saying zero contrast. I mean, we want to make sure that there are no ruptures. And for the CERT case, obviously knowing that the wire was in a good place once you cross the CTO was paramount. There's really difficult to do it any other way except for dilating using IVUS, and then it's too late because if you're not in the right lumen, you're not in the right lumen. But it also proves the point, it's not the complexity of the case that determines how much contrast you're using. It's really about having a good case planning and knowing how to utilize these quite simple techniques.
So I think we have a question from the audience.
It's not a question, actually comment. We use stent enhancement technique, which is available in most cath labs. That I think is being underused. I use it when we pre-dilate with the lesion and then take the enhancement image. It gives you idea about the calcium. And then after stent deployment, before removing the balloon, again take the stent enhancement and take it in 2 views. It gives much better idea about the expansion. And we also inject, whenever you want to inject fast. Otherwise you get inadequate image and you might have to repeat the angio again.
No, so thank you very much for your comments. We fully agree that the stent enhancement is extremely useful, and it's actually one of the things that help you more to reduce contrast use. Absolutely. And if you're going to do a good contrast injection, do a good one. I fully agree with you. So if you do it with diluted contrast, it's better to try to increase the frames per second to achieve good image. The worst thing is doing injections that doesn't serve any purpose and you don't see anything. I fully agree.
Dejan, would you like to illustrate? And of course, we can take another question, please.
I have another comment. In the case, for example, in this case that you have a CTO and you have only homolateral collaterals, and you want to reduce the contrast, sometimes I put microcatheter in the homolateral collaterals and inject from the microcatheter. So I can reduce the contrast, I can see better, and you're lucky or you're very good to reach the true lumen with the first try, but sometimes you have to try more times. So if you put this microcatheter in the homolateral collateral, you can reduce more contrast.
Yeah, absolutely. This is a very good comment, and we do it when it's all the type of CTOs. This was kind of a CTO that crossed with filter XTA, and you know very well when you more or less know that you are in the right place, and this was the case. So the wire behaved very well from the beginning, but it's a very good trick and helps reducing contrast, as you say.
Yeah, so I think we can highlight a difference or a continuity of the cases, of the two cases. So in the first, there was a strong, let's say, highlight of the planning. And in the second, you could see the benefits of the planning with IVUS, but also with the co-registration. And it really helps you. And I think what the second case added is this component of instantaneous guidance. And I wanted to highlight this here, because here is calcium. Now, of course, you knew, right here you can see actually calcium. And it's here as well, this here. You knew that from the IVUS. But the IVUS planning was at one instant, and the second instant is the real procedure. And we know it can change. The patient can move and so on. So I think it's also important to utilize like tools like stent enhancement and the roadmap, where you can have instantaneous guidance. And here it was important to remember that your landing zone is going to be just proximal to the calcium. So you don't have to give another contrast to see where you are with your stent. You use the existing knowledge from the co-registration and IVUS, you have that in your mind as the planning, and here for the instantaneous guidance, you rely on the stent enhancement that shows you calcium, and then you know that with your stent, you are going to be above that, and that you have to land here, just above the calcium. That, I think, was an important point for me. So you had instantaneous guidance as well.
Yeah, I think it's in this type of cases it's important to use all the possible markers you can have. I mean, and also you've seen we are always changing the views, looking in different views. The radiopack markers of the wires are very useful. Every side branch that can be useful, you can wire it and it can help. So really, all the markers that you can find, and that helps you be more sure about where you're implanting your stent are helpful. Calcium and side branches are the ones we use more, but you have seen the radiopack markers of the wires, and also, for example, for length, the radiopack markers of the catheter also really useful.
I think that we should mention also that with ultrasound, we can see the tibal calcification and to know if we want to use rotablation or not, if we want to use the IVL or not. So it's additional information which is hard, it's impossible to differentiate based on angio.
I think it also increases the patient safety as well. You know, if you're using these additional techniques, then I think you're less likely to cause harm to your patients. So
Yeah.
Yes. Please go to the mic. Thank you.
Is there a different approach when you're planning to do DCB? Because when you do DCB during lesion preparation, you would want to check whether you have a little dissection. So will this entail more contrast use, or you can still employ the same mechanism?
I think it's a great question. Because of course, DCB angioplasty is a different type of PCI, and one of the problems I see with DCB is that we still don't know for sure, or we have not defined very well what is a good result with DCB. As for a stent, this is very clear, and everybody knows what is a good result or not, and what are the parameters that we need to check to make sure that we have a good result. I don't think we have this information, for example, with imaging for DCB. So in this sense, it is a bit more probably challenging, but I'm sure it's going to be something that will develop in the future, because DCBs are increasingly used for this purpose. But yeah, it's a good question.
I think that most of the experience we have with DCB so far is in stent restenosis, but of course now there's a great interest in moving to other scenarios. I trained in the 80s when there were no stents and we had balloon angioplasty, so I know that depending on the quality of balloon angioplasty, you may have abrupt vessel closure. And I don't know, I don't want to be pessimistic, but I anticipate that as we start using more frequently DCBs, we will see situations where there will be acute vessel closures, because nothing of the things that we are using nowadays will prevent you for that if you don't make a good result. And from that aspect, having intracoronary imaging after DCB probably is something that may help you to identify that you had a major dissection that is not identified or whatever. So time will say, because now we are moving into this area of using more DCBs. But remember, DCBs do not provide scaffolding. It's true that we are nowadays using more potent antiplatelet treatments, but I would not be surprised that in 5 years from now, you have evidence suggesting that part of the safety of performing routinely DCB in the coronary arteries comes from having good intracoronary imaging. I would not be surprised.
We are doing the protocol on the understanding more the DCB, and once again, we don't use so much the angio and contrast. We use the OCT, and we do the 3D modeling of OCT and augmented reality pictures like holography to see the channels created by balloons, which are safe, which are not safe. So we are going in details, but once again with three-dimensional digital modeling and not angiography, to understand better what you said, the propagation of dissections. And channels. Yeah. We have one more probably.
Any comments? Yes, please. Thank you.
Thank you for great talks. Of course, there are several tools, and always we have to take into consideration costs. And I just wanted to hear your opinions about renal guard and saline-based OCT. Thank you.
Yeah, I think it's a technique that certainly is one of the techniques that may help in reduce contrast toxicity, because it delivers hydration to the patient according to diuresis. So it is the way of doing it. So certainly you can use any additional tool that you want to use to reduce toxicity. It's very important. But probably, as it has been highlighted by the speakers, what we are trying to promote is that ultra-low contrast PCI is important not only in patients with impaired renal function. It is important to take it as an habit, particularly in all complex PCI cases, because you never know when the complex PCI case is going to become more longer than expected at the beginning, when you have to move to contrast mode, etc. So if you spare giving contrast at the beginning, then you have more leeway to complete your intervention. That's why it was mentioned before that you can improve both the safety and the quality of your PCI.
So maybe Javier, I'd like to wrap up the session with our session evaluation and key learning points.
Perfect. So thank you very much for staying up to the end of the session, but just a very simple slide with some key learnings. the message has been highlighted in several occasions during the session. Reducing the operator's dependence to contrast opacification contributes to increase both procedural safety and to more comprehensive revascularization. Less is more is a sentence that we take from Dejan from now onwards. I think this is very important. Ultra-low contrast PCI is a compendium of interventional skills and dedicated tools. You can incorporate the renal guard, for example, whatever. Many of them available at the time to the interventional cardiologist in the cath lab. Nieves show us how displaying in front of you the previous diagnostic angiogram can be extremely important. Performing, saline injections to know if you have engaged your coronary artery, etc. Adoption of ultra-low contrast PCI starts with a change in mindset, follows with the application of its principle to simple cases. I think that the case that Matthias was showing us could be one of those cases, to be finally applied in complex interventions and patients like the one that Nieves was sharing with us. So again, thank you very much to you for staying with us until the end of the session. Thank you very much to Philips for sponsoring these educational events. Have a great day.